Now let's move to the second section of our lecture in which we will discuss now about the paralysis of recurrent laryngeal nerve. We already talked about the superior laryngeal nerve, and now we know that the major nerve supply of the larynx is by the superior laryngeal and the recurrent laryngeal nerve. So in this section, we will discuss the unilateral injury leading to the paralysis of recurrent laryngeal nerve and also the features associated with the unilateral paralysis of recurrent laryngeal nerve. Then we will also discuss the bilateral abductor paralysis, and it's bilateral and it causes the abductor paralysis, and abductor is the word that comes from abduction. The other term is adductor. Abductors are the or abduction is moving away from the midline, whereas adduction is from the towards the midline. So this is bilateral abductor paralysis, and then also we will discuss the treatment options for unilateral and bilateral paralysis. Recurrent laryngeal nerve paralysis. Here you can see the right vocal cord, which is normal, but the left vocal cord that is paralyzed with paralysis, you can see it's flaccid, the tension is lost, so that's the normal, and this is the paralyzed left vocal cord. The unilateral injury of recurrent laryngeal nerve, we have ipsilateral paralysis of all intrinsic muscle except the cricothyroid. Now we know that the cricothyroid muscles are supplied by the external branch of superior laryngeal nerve. So involvement of recurrent laryngeal nerve alone, now the cricothyroid is not paralyzed, and all the functions associated with cricothyroid muscle, they are preserved, but the functions of all the other intrinsic muscles, ipsilateral on the same side, it's unilateral, is paralysis of intrinsic muscles occur. Median and paramedian position of vocal cord. So median and paramedian position of the vocal cord occurs with the paralysis of recurrent laryngeal nerve. On deep inhalation or inspiration, no lateral movement of vocal cord. So no lateral movement of the vocal cord occurs because all the other intrinsic muscles are paralyzed, and the lateral movement of the cords is not possible. They are in the median or paramedian position. Again, we have Simmons' law, which is progressive lesions, abductic fibers of nerve. So abductor fibers of the nerves are affected, and the abductors are the muscles or fibers of the nerve that cause abduction, and abduction is moving away from the midline. So the lateral movement, as we mentioned in the previous slide, it is affected of the vocal cords. More susceptible and paralyzed first compared to adductor fibers. So abductor fibers are more susceptible to paralysis as compared to adductor fibers. And again, we should know the abductor fibers are causing abduction, movement away from the midline, movement laterally. Adductor muscles are movement towards the midline, movement medially. So abductors are paralyzed first as compared to adductor fibers. and the Siemens law. Wagner and Grossman hypothesis. What happens in this hypothesis, Wagner and Grossman hypothesis, the cricothyroid muscle innervated by superior laryngeal nerve cord in paramedian position due to its adductor function. So both now we know the two hypotheses. We have Siemens law in which the abductor are first affected. In the second one, the adductors are more affected, and there is cord in the paramedian position. So these are two theories associated with the laryngeal paralysis. Causes are the right, left, and both. We have the right recurrent laryngeal nerve neck trauma, benign or malignant thyroid disease, thyroid surgery, carcinoma, cervical esophagus, cervical lymphadenopathy. And then also aneurysm of subclavian artery, carcinoma apex right lung, tuberculosis of cervical pleura, idiopathic, no cause, no. The left causes in the neck, we have accidental trauma, thyroid disease, thyroid surgery, carcinoma, cervical esophagus, cervical lymphadenopathy. So if you see, both the causes are the same for the right and left in the neck. In the mediastinum now, the left is due to bronchogenic cancer, carcinoma, thoracic esophagus, aortic aneurysm, enlarged left auricle, intrathoracic surgery, idiopathic causes, mediastinal lymphadenopathy. So these are the causes of involvement of or paralysis of left recurrent laryngeal nerve in the neck and in the mediastinum. If both right and left nerves branches are affected, it is due to thyroid surgery, carcinoma thyroid, cervical cancer cervical esophagus, and cervical lymphadenopathy. So these are the causes. Mainly in the neck, causes are same, and mainly in the neck it can be both right and left side affected. Clinical features are the pass undetected, patients mainly asymptomatic. So patients are asymptomatic and it is undetected if patient is asymptomatic. Change in voice, no problem of aspiration or airway obstruction. Voice improves gradually, and compensation by healthy cord. So if one side is affected, usually the other normal side of the vocal cord can compensate for the voice loss. But if both sides are affected, usually it is not possible. So if undetected, change in the voice, if there are symptoms, if there is a paralysis on one side, the other side, the healthy side, can compensate for the loss. Treatment is no treatment as compensation occurs by healthy cord, injection of gel foam or fat, laryngoplasty type 1 if no compensation, laryngoplasty type 1 with arytenoid adduction, incompetent posterior glottis, and Teflon injection. So these are some treatment options. If there is compensation by the vocal cord, by the healthy cord, no treatment is required. But if the compensation is not possible, then we can do injection of gel foam, Teflon injection, laryngoplasty type 1 if no compensation, laryngoplasty again with arytenoid adduction. These are the treatment options for the paralysis. Now, bilateral abductor paralysis. The causes of bilateral abductor paralysis, we have neuritis or surgical trauma, thyroidectomy. Condition is often acute. Position of cord with bilateral abductor. Now, abduction is not possible, lateral movement is not possible, so all intrinsic muscles are paralyzed. Median or paramedian position of cord, unopposed action of cricothyroid muscle. So that's the position of the cord with the bilateral abductor paralysis. The cord is in the median or paramedian position. Abduction is lost and there is unopposed action of cricothyroid muscle because the cricothyroid muscle is not paralyzed because it is supplied by the external branch of superior laryngeal nerve. Clinical features of abductor paralysis: cords in median or paramedian position, airway is inadequate, dyspnea or difficulty in breathing, stridor, and attack of acute laryngitis. Treatment is tracheostomy, that's the tracheostomy tube inserted. In case of upper respiratory tract infection, long-standing cases, permanent tracheostomy, relieve stridor, preserve good voice. Disadvantages is tracheostomy hole in the neck. Surgical resection relieves airway obstruction at expense of good voice, no tracheostomy hole in the neck. So these are the two treatment options which are in the long-standing cases. We can do the tracheostomy or we can do the surgical resection. In tracheostomy, there is a hole in the neck, but in the surgical resection, there is no tracheostomy, no hole in the neck. Widening airway without permanent tracheostomy. Endoscopic or external cervical approach, widening of respiratory airway, arytenoidectomy with suture, arytenoidopexy, fixing arytenoid in lateral position, lateralization of vocal cords, and laser chordectomy. So these are again some options without the tracheostomy in which we can perform the widening of the airway, respiratory airway by arytenoidectomy, then arytenoidopexy, lateralization of vocal cords, and laser chordectomy. So these are other options in which there is no requirement of permanent tracheostomy. Kashima operation and partial arytenoidectomy. Methods are transverse chordotomy. Chordotomy is opening of the vocal cord in the transverse position, that's the Kashima operation. Soft tissue, junction of membranous cord and vocal process of arytenoid. Excise laterally with laser, provides good airway. Airway insufficient more tissue is removed depending on the condition of the airway. If it is more obstructed, more blocked, then more tissue is removed. Partial arytenoidectomy is medial part of the arytenoid. It's arytenoidectomy, removal of the arytenoid. It's partial, so the total arytenoid is not removed. Only the medial part of arytenoid is excised with laser. Sometimes vocal process of arytenoid is ablated. So all again, this is the other treatment option: partial arytenoidectomy and Kashima operation, in which the soft tissues are excised laterally with laser. It provides good airway, provides the relieve the obstruction of the airway. Depending on how much is the obstruction, the soft tissues are excised accordingly. Reinnervation procedure and thyroplasty type 2. Thyroplasty is repair, thyroplasty. Methods: reinnervation procedure, which innervates paralyzed posterior cricothyroid muscle. Implantation of nerve muscle pedicle of sternohyoid or omohyoid muscle with its nerve supply from ansa hypoglossi. Not very successful. So this reinnervation procedure is not a very successful procedure in which there is implantation of nerve muscle pedicle of sternohyoid or omohyoid muscle. Reinnervation means again the innervation or nerve supply trying to relieve the paralysis, but again not a very successful procedure. Thyroplasty type 2. We already went over thyroplasty type 1 and 2. It creates lateral expansion of larynx, similar to vocal cord lateralization done in type 1. Quality of voice not be good. So that was all about the section 2. Thank you for watching sqadia.com.